Okay, hopefully that has worked. Apologies for the delay. Just having some slight technical issues. But I'm very pleased to be able to introduce you all to our brand new pediatric series here on Mind the Bleep. My name is James, and I'm joined this evening by Dr. Helen Armstrong, who is a consultant pediatrician. And the session that we have planned for you is practical safeguarding. So just a little bit about myself to start with. So I am an FY1 doctor in haematology at Stoke Mandeville, but I have quite a lot of experience previously working with children both in the mainstream and special educational needs sectors. So I worked in a children's home and special school specializing in epilepsy, but also we looked after a lot of children that had difficult home circumstances, very challenging behavior, and actually I did a lot of safeguarding work there. I've also done support groups for young people with autism spectrum disorder, and throughout my kind of childcare career of looking after children between the ages of 3 and 12, or I've done about 10 years of sports coaching. Every year I have to go on various safeguarding courses, so I've become very, very familiar with it. And the last thing I want to highlight from that kind of mini resume would be I'm part of the safeguarding team at my hospital, Stoke Mandeville. So each week I meet with one of the senior pediatricians, the safeguarding liaison nurse. Is it not live? That's a slight issue. Hold on. Apologies, I've been corrected that we are, I believe, live, so apologies for that. Let me carry on. So yeah, between myself, the pediatrician, some of the nurses, one of the safeguarding liaison nurses, we go through all the recent cases that have been flagged up by the junior doctors, and generally kind of discuss, do we have any extra concerns? Do we need to raise it? And kind of what sort of mistakes have been made, unfortunately, by the juniors in their documentation or tackling of some of these cases. So just a little bit more about hopefully what we're going to try and put on for you guys. So over the next 12 weeks, we're going to have 12 different sessions put on by guest speakers that are all somewhat experts in their field, ranging from consultant pediatricians to advanced nurse care practitioners to fellow F1s and F2s that have a real passion for a certain area. This particular week, we are focusing on safeguarding and what you actually need to do as a junior doctor. I'm sure all of you had trust inductions or safeguarding lectures at medical school, but at least in my experience, I have found talking to my colleagues, a lot of people aren't actually that confident in what to do when they're working with children, whether that's in the pediatric emergency department or out on the wards. But before we get started, I just wanted to put a trigger warning out there. This presentation doesn't have any distressing images and no real kind of horror stories, but I know it's definitely a challenging subject for me to talk about from my own work previously, and whatever backgrounds yourselves might have, you might find this quite a difficult talk to go through, so just take it at your own pace. Obviously it is a live stream. If you were here in person, I'd say you're more than welcome to kind of take 5 minutes out and have a break. Okay, so just kind of take it easy. Okay, so what actually are we hoping that you guys can do? So if you're a medical student watching this, as a general rule, if you're prepping for your exams and you get a pediatric history particularly, we want you to show that actually with the questions you're asking, you're aware of all the different potential safeguarding issues and you're kind of ruling them out. And I know I spoke to Dr. Armstrong before we started, and she said, actually, if you come down to kind of the pediatric emergency department, we want you to recognize that there might be a safeguarding issue while you're taking your history, and then immediately escalate to one of the seniors who can take over from you, because it's really important. We want to keep children safe. We want to keep young people safe. And actually it is something that has to be handled very carefully. So by having a kind of an awareness of all these issues, hopefully that is something you will be able to contribute to. Now your F1s, F2s, that will actually be kind of working with children on a daily basis. We want you to be able to do a thorough assessment of children and understand kind of what you need to go looking for to properly assess safeguarding concerns, to pick up on things, little cues in your history or your examination that are actually of concern. Document it, and document it really well. I cannot stress enough, if you don't document something, you'll know this from all of your jobs. If you didn't document it, it didn't happen. But with safeguarding, there is a legal side to it, and this does get kind of transferred to social services, the police. Your documentation is so important for us to be able to interpret what is going on with that young person. And the big thing that we're going to come back to again and again throughout the talk is that we want you to escalate to your seniors and have a really low threshold for discussing any concerns, not just for safeguarding, but PEDS is a wonderful specialty because everyone is so supportive. It is senior led, and the only time they're really going to get upset with you is for not coming to them for help. They want to hold your hand, they want you to take you through it, and they want you to make sure this is done properly. And actually, if it's a difficult case, particularly in safeguarding, they're quite happy to take over. Would you agree with that kind of assessment, Dr. Armstrong?
I would absolutely agree with that. I think as James said, I've only ever been upset when people haven't told me, not when they have.
Fantastic. I know, yeah, people in PEDS is one of the main reasons I want to go into it, as well as all those lovely things I've done in the past. Okay, so why exactly is safeguarding important? So we thought we'd kick the series off with safeguarding because it is important, because children are incredibly vulnerable. If you look at the happy little chap that we've got on the slide here, he can't tell you what's been going on at home. He can't tell you if someone's been hurting him, if everyone has been meeting his needs. That is one of the biggest things, that he will not be able to tell you what is going on. So you, as a pediatrician or as a junior doctor, or as a medical student, have to be switched on to picking up the signs that something is amiss. And that goes as well for children with learning disabilities or mental health issues that, again, may not be able to communicate some of those issues to you. Furthermore, with children, they are easily led astray. So I used to work in care. I used to work with mainstream children. Big part of my job is convincing the child to do something they don't want to do, whether that's get up for school, it may be having a shower at the end of the day, it may be, eating with their knife and fork. I had 1,000,001 tricks, and I would persuade them to do something that initially they did not want to do. And that is exactly, unfortunately, the same thing that can happen to children. They are led astray, and it means they engage in things that they shouldn't be. And that is kind of where abuse can really easily happen. And a lot of our children, they are very dependent on the adults around them. And they do trust adults, and that is fantastic in some regards, but again, it makes them incredibly vulnerable. You, as a junior doctor, may actually be one of the only professionals to have sufficient access to identify some of these issues. So in the last couple of years, we've had COVID, which means children are at school less. They're going to less kind of out of school clubs, less sports clubs, less youth things. They're having less contact with the normal professionals that pick up these issues. But on top of that, as a doctor, we get to be super nosy. We get to ask all the questions that we want. We get to really delve into what's going on in that child's life. And on top of that, we quite often get to examine all different parts of the body in a way that your school teacher does not, which means that we're in a very privileged position, but also have a big responsibility to be the ones to pick up this stuff. And as a doctor, I'm sure you're already aware, you have a duty of care to your patients. You have a legal responsibility, in fact, for some of the reporting within safeguarding, but we're going to touch on that a bit later. Okay. So focusing on the theme of kind of vulnerability. So we're just going to go through a few factors that you just need to have in the back of your head. If these things are present, it makes the young person or the child more susceptible to abuse or neglect. So if you look at kind of their family circumstances, things like a low socioeconomic status, if the parents don't engage with healthcare, so if they're not really listening to you when you're trying to tell them how to manage their kids' asthma, that's not a good sign that they're taking a good care of the young person in front of you. Similarly, if they've previously suffered abuse themselves, if they have mental health issues, substance abuse, domestic abuse, these things all increase the likelihood of children unfortunately suffering abuse. But that is absolutely not to say, if you look at some of this list and you're a parent yourself and you think, well, maybe I fit into one or two of these things, we're not trying to say that this means that you are going to abuse children. It just means in the back of your head, these are factors that statistically make it more likely. Okay, and then when you look at the child, different ages, different sexes will predispose children to different types of abuse. And that is something you will get a kind of a feel for the more that you work with young people, unfortunately, the more the cases you're involved in. But if they've had previous abuse, previous trauma, if they're a kid in care, if they've got learning disabilities, like we said before, where they can't tell you things, or they can't process things in the same way that a child of that age would, these all increase their vulnerability. Is there anything that you wanted to add to any of that, Dr. Armstrong?
No, I think that's all really relevant. I think, as James said, this is not about judgment. This is just about being aware that these things sadly are the case. One of my favourite families probably ticks all these boxes, and they're absolutely wonderful parents. But sadly, we know statistically that these things do make it more likely.
Okay, so now one of the big topics we're going to move on to is assessment. So this is a QR code that links to a Padlet. I'm also going to post some links, hopefully, alongside the video. And what I'd like you guys to do is go in and have a think about some of the questions that you would like to ask in a history with any child that comes into paediatrics, that helps you identify safeguarding concerns. What are the things that kind of we're really concerned about? What questions are you going to ask every single consultation? What are we going to ask of our teenagers specifically? What are we going to ask of our primary school age children? How are we going to approach it? How are we going to phrase the questions? And I think I've as well on the Padlet, I've put kind of different headings that you can post your ideas underneath. And similarly, I've divided up the different types of abuse and neglect. So again, you can think about the different areas that you want to approach and kind of investigate. So if you have a quick go at that, like I said, you should be able to scan it with your phone, and on the event I have got the links. I will see if I can quickly add that to the video as well. Okay, so let's have a quick look, and I'm going to kind of take you through the things that I've come up with. So in every single consultation, we want to be asking kind of, is there any social services input? And I ask this of every parent that I've kind of clerked one of their children's in the kids emergency department. Make it a routine question. We've just kind of discussed before, these are one of the things that make it more likely. It also means when we escalate to social services or the police, they know that they can go and look someone up if they have had previous contact. We also want to think about who else is at home. That's important because brothers, sisters, for example, they may be having issues themselves, and that's going to have an effect on our child or young person. But also if mum or dad are bringing in kind of partners or friends, if they're abusing alcohol, if they're abusing drugs, that again puts the child at a bigger risk.
I just want to jump in and add that when you're thinking about who's at home, if you're worried about safeguarding and the child you've got with you, you also need to consider that there's then a potential risk to those children still at home, and who will be looking after them if you are initiating safeguarding proceedings with the child you're with.
Absolutely, and that is really important. And also, if when we're kind of who is with them is what I was thinking there. So if you think about it again, who has turned up to the emergency department, if we're going to assess kind of the relationship between the child and this person, we need to know who they are. It's very different how you're going to act with your mum or your dad to your PE teacher that brought you in halfway through the school day. And what's appropriate with each is going to change, and it's going to be very different. We also want to think about the timing of the presentation. Is it reasonable that they've waited 4 days before coming to talk to you about something? If it's not, that is kind of one of the things that might be tipping you off and thinking, okay, well, maybe this is neglect. Maybe there are other needs that aren't being met here. We can also ask about kind of, how is school going? How are things at home? I'm sure Dr. Armstrong agree, kids are not very good liars. Generally, you get up front, you get a pretty good sense of what's going on, because I mean, rolling their eyes and saying how school is kind of boring is very different. Dreading going in every day, having panic attacks and crying because they're being bullied or they're being hurt when they're at school.
The other thing it's worth asking just around school is that if you're thinking about neglect, rather than say something really obvious like a physical abuse, it's quite difficult to prove that. But some of the quantitative things you can assess are school absences. So as in, have they been absent 1 day a week for every week for the last 6 weeks, etc. And that's really helpful.
Absolutely. That's a really good point. And similarly, how often are they coming into hospital? What's been going, if they're coming in for the same thing again and again, kids are accident prone, but if this is the 4th time you've fallen down the stairs, are you being appropriately supervised? Is there kind of a danger in the home that the health visitor needs to go out and see? Looking for patterns is really, really important. And we're going to touch on this a little bit later, but for teenagers, we're going to be thinking about relationships, drugs, alcohol, suicidal ideation or mental health issues, although I know we are now seeing a lot more of that in primary school age children. But definitely it's something to have in the back of your mind with teenagers. And if we think about how we want to lead this, it's similar to all the histories you're going to be doing anyway. So patient-focused or child-led where appropriate. Like we said, when we were looking at kind of the baby that probably can't speak yet, they're not going to be leading the consultation, but absolutely getting, your 7-8-year-old to kind of tell you a bit about what's going on in their own words. That is really, really key, and you'll get a lot more useful information that way. We want to ask nice open questions. We definitely don't want to be kind of taking a child down in one particular direction and getting them to kind of agree to things that may or may not be happening, because then we're kind of putting words in their mouth.
I find a really helpful question if you're struggling with open questions and safeguarding is, after you've said, so tell me what happened, asking things like, and then what happened next? Because that way you can lead them through their history, but without leading them.
Absolutely. That's a really nice tip, actually. A really good way of just moving it along, but leaving it entirely up to them about kind of where you go with it. Be non-judgmental. It's kind of quite casual. It's quite routine. Yes, you're taking it seriously. You're not kind of having a laugh about it, but you're not going over the top, being shocked or kind of reacting and being overly emotional to it. You may be feeling like that inside with some of these things. But if you think about someone kind of divulging some information to you, you need to feel the person that you're divulging it to isn't judging you, and that this is, something they do day to day. Okay, so we have another case and another Padlet, which should be posted in the group. I'm just going to double check while we do that. So what I want you to think about is what you want to know about this case. So you get a 14-year-old girl that comes in, her parents, so it's not very child-led, tells you, she's been very tearful, very withdrawn at home, a bit irritable. In fact, sometimes she doesn't even go into school. Her grades are all going pretty downhill. The teachers are saying, she's not quite the same kid she was before. And all this seems to have started not long after seeing a new boyfriend. And the parents they're brought her in because they're really worried about her mental health. So think about, what is it that you want to know? So jot down a few ideas. I'm just going to check on the video, make sure it's doing what it's supposed to. Okay, so let's see if some people have managed to access that. not much is coming through, but we're going to kind of crack on and discuss it anyway. Okay, so in this case, it's kind of focused around relationships, and this, this can go all the way down from primary school age children all the way to teenagers. And actually, if you work with adults, kind of vulnerable adults, you need to be thinking about the similar sorts of things here. So thinking about the age of the partner in relation to the young person in front of you. So while many of you will know, in the UK, for example, the age of consent for sexual intercourse is 16. That doesn't mean two 15-year-olds that are having a sexual relationship are breaking the law, because it's an appropriate age relationship. You would counsel them, see that they understand it, talk about things like contraception, protecting themselves from sexually transmitted diseases. But you do start to worry when there's a slightly larger age gap. So if our 14-year-old is seeing a 17-year-old and 18-year-old, it may not be quite so appropriate, and you kind of need to assess that on a case-by-case basis. That being said, anyone under the age of 13 cannot, under any circumstances, consent to any sexual activity, even that's with another 13-year-old, another 12-year-old, doesn't matter, they are too young. It is illegal. You need to report it immediately and escalate it as soon as possible. Ask your consultant, ask your registrar, and probably they would want to take over that sort of case. If you're not really sure, because you think, well, okay, they're 14, the boyfriend's 16, is there a power imbalance there? Is it a bit odd? Again, ask your senior. They will be able to help you, explore it fully. Do you have something you wanted to chip in on that?
Yeah, I would absolutely agree with that. I still remember the case when I was an ST8 of a young lady that came in with abdo pain that everyone thought was appendicitis, that turned out to be PID, because she had been in a relationship with an older boy who was only about 18, and she was 13, 14. Wow. It took a lot of unpicking. My consultant helped me do it, and I was quite a senior registrar. So I would always rather know about this early doors, and if you're worried, just ask.
No, absolutely. Yeah, cannot emphasize that strongly enough. So in addition to that, if you think about, when you were young, when you were a child, a teenager, how big peer pressure is when, your first kind of relationships and stuff, the ability to lead each other astray and things like drugs, alcohol, all of that is really big. So it is definitely something you need to be inquiring about, particularly if you've seen a significant behavior change. But not only that, is there pressure coming from one side or the other? Is there any blackmail? Is it, is the reason that the behavior has changed actually is because one side or both sides have unrealistic expectations of what a relationship means? And it's really hard to tease that stuff out, but it is important to kind of, delve deeper. And if that means you have to see the young person, without their parents for 10 minutes and see if they'll open up that way, that is definitely something you can kind of try to facilitate.
My top tip would be, not only for safeguarding, but in clinic as well. I always open it up by kind of saying, would you like to have a chat with just me and maybe one of the nurses for a few minutes? Some young people say no, some say yes. And particularly in these kind of circumstances, if you're wanting to ask about sex and boyfriends, I usually say something along the lines of, so I've got a few probably slightly embarrassing questions to ask you. Would you like your parents to step out, or are you happy for them to stay? And actually, some young people are so open with their parents that they really don't mind they stay in while you ask them about sexual relationships. Some of them are obviously much more cagey and would like their parents to step out.
Right, absolutely. I know which of those two I definitely went into when I was a teenager, and maybe as an adult. But yeah, I've always been amazed at actually how open relationships are with some families, and it is really nice to see. But on top of that, we do need to be also thinking about, is there any kind of domestic violence, that kind of physical violence between a couple? Also, a big thing that's come kind of, more recently, explicit image sharing. So the idea that, they would be sending images back and forth, and they have a falling out, and one of them shares it with their friends, and it goes around the school. So as well as all the kind of legal issues around child pornography, it can be used for things like blackmail, bullying, and it's really, it has a massive effect on someone's mental health. And as well as thinking of the age, if there is kind of sexual activity and appropriateness, we do need to think about their cognitive abilities. So yes, they may be the same age, but actually if one of them even has a slight learning disability, but has the mental age of a 12-year-old, a 10-year-old, or some other sort of vulnerability, that does need to be taken into account. And again, kind of your seniors or your more experienced are the ones that you want to be running this stuff by. And then if we just kind of go back to the case, so the parents are worried about the mental health. Of course, we need to screen for all the usual mental health issues that we would with our adult patients, all the stuff that you kind of, the way that we risk assess, the way that we, try and pin down exactly how it's affecting their day-to-day life. Really, really important.
You can still use your mini mental state assessment as you would in adults, but just tailor it to the child.
Thank you. Okay, so now if we think about our assessment or our examination, so general principles, throughout the history, you want to be observing. There's a lot you can pick up without, formally examining a child when they're in with you. How are they playing? How do they interact with mum or dad? Or like I said, that PE teacher that brought them in the middle of the day. Is it kind of respectful? Are they playing up because they're in a new environment? Or do they seem, frightened or on edge? Or are they always looking for someone else to answer? And that's something that you can pick up actually just while you're taking your history, and can make up a big kind of part of the whole impression that you get.
The other thing that should maybe raise a little bit of a red flag to you is kind of the polar opposite of that, when a child's overly friendly and kind of wants hugs and attention from nurses or doctors, because that's often a sign that they're not getting it at home.
Definitely. Which actually brings us on to one of the kind of concerning findings down here. So inappropriate behavior. So if you've got kind of a younger child that's actually, talking about things that are quite sexual, or talking about drug use or alcohol abuse, and it's not appropriate for their age, that does again raise questions. Is there some sexual abuse there? Are they being exposed to things that they shouldn't be? And actually, unfortunately, a lot of children that have been sexually abused will kind of start experimenting sexually with their peers, and acting in a way that really isn't appropriate. And that can be as silly as going up to a stranger and hugging them and stroking their leg. That's, if they're 3 and they're upset, it's not odd necessarily. If they're a bit older, it can really be. And it's a judgment. If you work with lots of children, you may have a sense, but again, escalate to your seniors or your more experienced nursing team for that. Fully exposed babies, again, they can't tell you what's been going on, so you want to see head to toe. You want to look for rashes, little bruises, cuts, all those things that, again, they might give you the diagnosis for the medical problem, but also they're going to expose a lot of safeguarding issues, kind of bruising, or if there's been any kind of trauma there. Enlisting the parental help if appropriate. I'm sure by now most of you will at some point, perhaps in GP practice, have to look in someone's mouth or ears that's about 2 years old and doesn't trust you because you're a stranger. Getting them to sit on mum or dad's lap or help you with distracting, or even, if appropriate, holding their head. That can be really helpful. Obviously, if we've previously been quite concerned about the way they're interacting with mum or dad, we may kind of, consider not enlisting help in that way. But for most kids with appropriate relationship, having their parent helping out is going to make them more comfortable, more cooperative, and make your examination more thorough and easier for you. You will need a chaperone. Do get one, and make sure you write in your notes who it is. It is important, and it's important legally, and it protects you, not just the child and young person.
So the only point I wanted to add to that is make it be a chaperone that can stay there for the whole time, because sometimes your nursing or HCA colleagues will try and bob in and out. That is not what you need. I often prefer to take one of the junior doctors with me. I will happily take with me an FY, an ST, because they will stay with you the whole time.
Yeah, absolutely. Okay, and then kind of moving on to things that are going to worry us, so concerning findings. So any injury at all, really, if it doesn't match the history that you've just taken, so you've done a really thorough history, you found out what's been going on, but the bruising pattern that you're seeing, or the cuts, or the broken arm, it doesn't really add up with the story that you've just been told. But any trauma in a non-ambulatory child, so that is a child that is not walking, any bruise, and we were talking about this before, weren't we, Dr. Armstrong? So any kind of burn, any scald, you're going to refer that immediately. And it may be, and it does happen that, you know, mum was playing with the little one on the floor and kind of slipped over and they banged their head. It happens. It makes sense. They might have a little bump. You still need to refer it. And it is because they are especially vulnerable, non-ambulatory children. But also, if you're not walking, there are only so many ways that you can kind of hurt yourself in that regard.
And I know it seems crazy, but it is actually a legal requirement that we, as the paediatric team, discuss this with an MDT. So that means even if we agree with you completely that this is accidental, I still have to speak to social care and tell them that that is the case. So it's really, really important that in those non-ambulatory children, you refer them straight up to peds.
Absolutely. Okay, so, and then the other thing with, if you look at the diagram over on one side of the slide here, so certain injury patterns or locations. So children, they run around, they do silly things, they trip over. So skin knees, bruised elbows, it happens. It's not necessarily something that's going to immediately concern you, but there are certain areas of the body that you're going to immediately worry about. Anything around the kind of groin or genital area. Yes, sometimes someone will fall down and kind of, you know, split legs over something, and that is a story that adds up. But we do need to make sure that we are fully investigating it, documenting it. You may have heard of the triangle of safety. So that is kind of from the ear down around to the tip of the shoulder. It's an area that you can't really accidentally fall onto. So if you're getting injuries in this area, it strongly implies that something is hitting you rather than you tripping over and banging yourself on something. Again, issues around the eyes, the abdomen, the chest, any bilateral issues, cheeks definitely is, again, when we fall over onto the floor, these are not areas that we're likely to hit. And, you know, if I've got bruises on both of my shoulders, unless I'm, you know, inside a bin rolling down a hill, it's unlikely I'm going to be, there's not many mechanisms of injury that can cause these. So we need to ask more questions, and we need to be really thinking hard. How has this happened? Could it have been non-accidental? Are there any other ones that you wanted to pick out, Dr. Armstrong?
So I would also be cautious about thighs, especially inner, but sometimes outer as well, depending on what the mechanism is. Bottoms, so if you've got a small mark on the bottom, if they've fallen on a toy, fair game. But actually, bottoms are fairly padded and they don't bruise that easily. And spine. So although that's a bony prominence, it's really hard to get a bruise on your spine.
Absolutely. Yeah, so they're all good areas to kind of look out for. But similarly, if you've documented it, go discuss it with someone. There are people that will have seen hundreds and hundreds of these injuries and will have a really good idea. So in my previous work, we did lots, you know, we worked with children with epilepsy. So we saw lots and lots of bruises from that side. We also worked with very challenging behavior and a lot of restraint. So again, I know what a finger bruise looks like. I wouldn't expect a brand new F1-2.
What I would say from James too,
and it's, always rely on your colleagues to pick up.
Yeah, is that even as a consultant, you've never seen everything. Nobody has. We peer review each other and each other's cases, and the reason why you have a safeguarding lead is so that you can discuss. And if you're ever concerned as a consultant when somebody's referred something to you, you go and discuss it with another consultant.
Absolutely. No, it's a very open kind of team environment, isn't it? It's kind of everyone gets involved. Okay, so moving on to another case. So what I want you to do is kind of have a think in your head, either stick it on the Padlet or even on a piece of paper in front of you, or really commit to an answer here. Are you concerned about this case? So we've got a 42-week-old boy, and this is what has been documented in their notes by the junior doctor that's been to see them. They fell at home. They immediately cried. They played normally throughout the afternoon. There wasn't any vomiting. They've got some bruising on their head and their arms, a little bit of swelling. You know, they were quite good. They looked at the trust guidelines and saw that a CT head wasn't indicated. So they discharged them with some safety netting and a head injury advice leaflet. So is this something immediately that makes us go, "Ooh, we're very, very worried about this," or no, I'm sure this was fine? Again, I'll see if I can see it on the Padlet. Okay. So we're getting a few bits and pieces in here. See it under the "Are you concerned?" If you just want to put yes, no, and then what things we want to know a bit more about. Oh, yeah, so I've got a good answer here from someone. It says not too concerned, but would want to know how long between the accident and the presentation. No, very good question. So the purpose of what I presented here is each week in the safeguarding meeting that I go to, we see loads and loads of doctor's notes that look exactly like this. And we are having that MDT discussion to say, are we concerned about this? And it's not that we think that all these good questions that are coming in haven't been asked. We actually trust most of the junior doctors to ask the right questions, to have the difficult conversations. But if it hasn't been written down, it didn't happen as far as we're concerned, and we can't really assess whether or not, they fell. What exactly does that mean? So now this is a much more detailed thing that will still map to this case. But 42-week-old boy that's ambulatory, so they're walking around, they're fully walking, they're up, they're going. They can get more injuries than someone that's not. They were seen with their father. There was appropriate interaction, so we've always got that in the back of the head. Are they appropriately interacting with the parent that's brought them in? And this is a key bit here. We've got a description that hopefully you can, just as well as I can, you can picture this in your head. So you've got a young kid walking around, they trip on a toy, they fall forward, they put their arms out to catch themselves. As they fall, they hit a plastic table, they bump their head, but the weight goes onto their elbows as they hit their floor. Mum saw this happen. So that's probably why we have such a good description. The injury occurred at 12 o'clock. So for the person that was asking, how long did it take them to come in? They came in 2 hours later. So they played normally for a bit. Mum and dad got their coats together. They might have had to sort out childcare for someone else. But the bruising on the head and the arms, we've measured it. We've said it's a 2-centimeter bruise, and it's on the right side of the forehead. There's redness on the elbows, C body map. So they've done some of the paperwork where they've actually drawn on a picture of a body, this is where the injuries are. So you or I reviewing this know exactly what injuries we're talking about. And as you can see, that you can imagine how that child has fallen. And actually, yeah, I could see them bumping their head. I could see them having some redness on the elbows. It makes sense. So they've assessed as well the child's behavior. They seem quite content, but a bit shy, which in a 42-week-old, they're just starting to get stranger anxiety. So it's very normal for them to be hiding behind mum or dad, or well, it's dad in this case that's brought them in. We've discussed it with Dr. X, our imaginary PED special registrar.
So that's where I just want to jump in, because for everything safeguarding, now it might vary slightly from trust to trust, so please check in your own trust. But for all the trust in West Yorkshire, it goes straight to the consultant.
Interesting to know. I'll have to check at Stoke Mandeville with the exact way it works. But whoever you do discuss it with, document who they are and what their role is, because discussed it with the other F1 is not the same as discussing it with your consultant, or discussed it with the HCA. While valuable, it's not the same level of review. And the final thing they've written is no safeguarding concerns, and that's something I like to write at the end of pretty much any history that I've taken from a paediatric child, if I'm not worried. Because even if I haven't done a great job of describing all this, it at least tells someone else that reads my notes, James has thought about there could be some safeguarding issues. He's asked some questions about it and decided, on balance, there wasn't an issue that he wants to bring forward or delve into further. And that's quite a reassuring thing to see written down. Now, similarly, going back to this vague history, equally, it could be something much more worrying. So I'm sure many of you will have come across the idea of cruising. So where they're starting to walk, but they have to hold on to either a toy, sofa. So they're not fully ambulatory at this point. So this boy fell at home, but he slipped on a wet floor and he fell backwards. So his legs came out from under him and he went backwards. The injury was at 7 a.m. yesterday, played normally throughout the whole afternoon. Excuse me. But presented the next morning. So that is a little bit suspicious. And sometimes there's a good reason why they couldn't bring the child to the hospital in that time. But if you're particularly worried about the types of injuries, if it's a severe injury, you would expect them to drop everything and bring them straight away. Okay, so we're thinking, so we've got some bruising on the head and arms. That can equally be a laceration to the forehead, a bruised left ear, bruises on the shoulders, under the arms, because we described some bruising on the arms. And they appear in different stages of healing, which implied they didn't all happen at the same time. So this kid has been in the wars and has been getting lots of different bruising, and that is something that we're going to be really concerned about. But you can see, rather, again, this is a slightly artificial exaggeration, but you can see how that does fit into the description, bruising on head and arms. So we want you to be really, really specific when you document this. And we just added in at the bottom, the child is quiet and withdrawn, another sign that we're going to be a bit concerned about them, because they're not playing, they're quite, timid, and as you can imagine, if they have, been hurt in a way that's, quite scary, quite abusive, they are going to be a bit quiet. They are going to kind of be a bit fearful of their surroundings. Okay, so that brings us on to documentation. And documentation is really important. Like I said, I attend a meeting every week where we talk about documentation. It sounds thrilling, I know, but actually going through it and seeing what people have written down, what they've considered, it's very important, because a lot of the actual concerning cases, they will be escalated to the police, they will go to social services, and the notes that you take not only inform these other specialists, but may be used in a court of law. Now, your registrars, your consultants, level 4, level 5 safeguarding training, they will get training on how to write statements, all of that important stuff. But that does not mean that they will not also pick up your notes and have those read out in court. So if you haven't done a good job, it can mean that actually, they don't get a prosecution, or, things can't be justified or put in place. And that's, that's letting the child down, and it's really something that we want to avoid. So generally, you want to think, who came in with the child, not just because of the relationship there, but if they deteriorate suddenly and you need consent to rush them into surgery, the fact that you haven't asked who this adult is, and it's actually the next door neighbor or the geography teacher, whoever it is that's brought them in, they may not actually be the person that can consent to this. And if no one's bothered to ask who they are, you're not going to realize that in time. This is a very minor thing, but it is definitely a bugbear of mine. So children don't DNA or do not attend clinic. They are not brought. They are not the ones choosing not to come in, not to get medical treatment. It's a reflection on those looking after them, not a reflection on the child. Were you about to jump in with something, Dr. Armstrong?
Yeah, I think we may have said it before when we talked about history taking, but when it comes to documentation, it is really key in safeguarding cases that for both the adults you speak to and for the children, that you write down verbatim what they say to you. So I know that a lot of the time in our notes, when we're taking a normal history, we kind of paraphrase what they've said, and that's fine. But for safeguarding, sorry, it's critical that what the parent or what the child says is written down, because that is very important legally.
No, absolutely. Yeah, it's really important to get that word for word, and it has a total different, the way that you might paraphrase it can very much change the meaning. So we've talked about body maps already. They should be available in your trust. If not, draw one. It doesn't have to be pretty. Just stick something that tells me as the next doctor coming along where that injury was. So if I look up when they previously come in, okay, they had a bruise a week ago up here. So when I see a bruise up here, I go, okay, that looks like a slightly healed bruise.
When we're talking about bruises, we know that you cannot age bruises. There's no evidence that you can, but we do know that if you've got bruises of different colours and different ages, that makes us worry more.
No, absolutely. We've talked about, I think, most of these bits and pieces. One thing, planning for the paperwork. So, when we're doing our multi-agency referrals or information sharing, who is going to do that paperwork? The answer is probably you. But if you're the responsible person, document that, because that way, if it hasn't been done, it hasn't materialized, we can chase up the right people. And we are going to be, putting some details into the interaction, the behavior, the appearance. They don't have to be following the latest fashions, but if their clothes are dirty, tattered, does that make sense? If it's after school and they've got grass stains on their shirt and their trousers in the summer, what, they've probably been playing football. If it's, the first appointment of the day at 9 a.m., why are they covered in mud?
My favorite word that I ever learned from one of our safeguarding leads was grubby. Like, the child looks grubby.
Yeah.
Because that way you're not saying that they look that they're just completely covered in dirt. And then my other top tip that I only picked up when I had a case where it mattered was nails, and not just the nails of the child, the nails of the parents. Because I had a child that looked like they were covered in little half moons all over their back. And my consultant, when I went to discuss it, said to me, well, how long were the mum's nails? And I was like, I don't know. So weirdly think about some things that you might not usually think about.
No, definitely those sorts of observations, and then stick it in the notes, make sure the next person can interpret that. Okay, so then we have another case. So this one is, you've been working in one of the pediatric wards for a couple of weeks. One of the patients, they say, oh, do you mind, Dr. James, can I have a chat to you after the ward round? So I go back and I say, what's going on? And they say they've got something really important to tell me, but I have to promise to keep it a secret. So how should I respond to that? So have a little think, commit to what you would actually say to this young person. You're a little bit worried about them. So, are you going to say, oh yeah, I'll keep it a secret? Or is it, is there something else that you might want to be saying or not saying to them? Okay, so this case was all about disclosures. So we're thinking kind of do's and don'ts. Absolutely have a chat to them privately if they're more comfortable, but you need to explain to them who you might have to tell. So if they disclose some abuse, or if they tell you that, their little brother is at home and, they're being hurt by their parents or something, you have a legal duty to report that. But if you've just promised to them that you were going to keep it a secret, and then you have to go back on that, you're going to betray their trust. And not only, we don't like to break promises, but for a child, that may stick with them for a really long time. They may never make another disclosure again. They may never trust another healthcare professional, another adult again. So you cannot promise that you will keep it a secret. But do reassure them that you're not going to just, go back to the nurse's station of the doctor's office and tell everyone. That's not something we're going to do. We're going to tell the people that need to know, and we're going to update them on kind of what we're doing if it's appropriate. So, your 3-year-old doesn't need to know, well, I told the safeguarding lead and they sent some emails. That's not important. But your 17-year-old might want to know exactly who's been involved, who might come down to see them. Like I said, don't make promises, don't ask leading questions. Let them say it in their own words and document it in their own words. And if they give you a bit, but they don't want to tell you anymore, that's fine. Leave it there. Like, take it at their pace. It's not easy for these children to make these disclosures to you. And the fact that they trust you enough to come to you and say this is amazing. And it's a real privilege to receive a disclosure. It's upsetting. It's horrible because obviously the abuse has happened. But the fact that they trust you is really important, and you want to just maintain that relationship.
The same thing that James is saying is true of when you're examining a child, particularly if you have to examine genitalia, especially on a younger child, kind of the 2, 3, 4-year-olds. If they are uncomfortable, the worst thing you can do is push them to do it all at once. It is better to do it over 2 or 3 sessions if needed than to force them and completely break that relationship.
Absolutely. And the relationships are really key. And these early kind of years experiences stay with kids for so long. So it is important the way that we do treat them. So the way that I used to phrase it for both young mainstream children and some of the children I used to work with that were teenagers but with mental ages that were quite young, is that, if you tell me something, absolutely it can stay between me and you. But if you tell me something where I worry that someone might be in danger, I'm going to have to tell someone so they can help that person. And I've had kids as young as 3 that understand that if, they tell me that someone's in danger, I'm going to get them some help. And I used to work with a 17-year-old girl. I told Dr. Armstrong this earlier. And, we got on really well. She was 17. She was about 6 inches taller than me, big, bushy, curly hair. But she had the mental age of a 2-year-old. And she was absolutely lovely, but she would like to, come up to me and be like, "Oh, James, I've got a secret to tell. Can I tell you a secret?" And I would rattle that off. Well, I'm going to have to, tell someone if someone's in danger, but go ahead. And the secret was normally we're having sausages for dinner, and that's fine. And I would still rattle this every single time. I would still say, well, I can keep it between us, but if there is any worries there, I'm going to have to escalate it. And just in case, at some point she could have told me something significant, and I would never want to break her trust. And it's really, really important. You might feel silly doing it, but it's something you really need to get into the habit of doing if you do work with children and young people. Okay, so we're coming up to another case. So again, you can get on the Padlet, and I think maybe under what do you want to know, or any of the headings really, you can put kind of what you should be doing next in this case. So during a consultation, you notice that your patient's older sister, that's about 12 years old, is uncomfortable sitting on her seat. She's kind of squirming, can't quite get comfy. And she excuses herself to use the bathroom about 3 times in 30 minutes. Now, from the history you've taken from the mother, and you're taking it around your patient, you discover that they've recently returned from a long holiday in Sudan visiting family. So kind of what would you be asking about? What are you concerned about here? Why have I put this case in? I have a little think. I'm going to try and grab another sip of water. I'll see if I can refresh the Padlet and see what sort of stuff is coming in. Oh, so we have a comment here that has got it right on the nose. So I'm very worried about FGM.
So what I'd encourage is, I know we're talking about safeguarding, but obviously there's other things that could be going on here. And much like you think about your surgical sieve in every other case, I'd encourage you to do so now, because let's be honest, sometimes we're so good at focusing on safeguarding that we forget the obvious, because this could be a UTI.
Yep. No, absolutely. Absolutely. That's a really, really important point. Yeah, don't, if you hear hoofbeats, don't think zebras. It's kind of, yeah, absolutely. But the case we're kind of trying to make here is FGM, or female genital mutilation. It's really important that you're aware of this. In this country, it is illegal. As a doctor, you have a legal duty to report if you suspect that FGM has happened or will happen, and you can be prosecuted for failing to do so. So the fact that you suspect that it may happen in the future, or it might have happened in the past, it's pretty strong that you have to then report this. Not only is it illegal, it has to be reported to the police. And you may sometimes have conversations with families saying that they're planning on doing it and there's nothing you can do to stop them. If you take a child out of the country to perform it, it is illegal and you can lose your right to stay in this country. So the signs we are looking out for: prolonged travel to a country of origin where FGM is common. Yes, this is kind of profiling, it is stereotyping, but FGM is a practice that only happens in certain communities that are typically from certain areas of the world. It doesn't mean that everyone that goes to Sudan is planning on some sort of female genital mutilation, but it is something that you need to consider and you need to ask the questions. Okay, so if they have someone in the family that's already undergone it, that is, an indication that they belong to a culture where they do practice this. Okay, I have no idea what that is. That's just another wonderful technical thing that's going on there. Probably not the most appropriate moment, but carrying on. So frequent urination, again, linking into our UTI, but it is a sign that FGM may have been performed. Similarly, depression or withdrawal can happen both in a young girl that knows that it's going to happen. They can get quite anxious, quite worried about it, quite depressed. But similarly, if it has happened, it can then, again, really affect their mental health. And a reluctance to be examined.
The other thing that I just wanted to chip in is, especially when James was mentioning about your legal responsibilities, is that you'd be surprised at what level of challenging conversation you can have. that remains very civil. So I've had conversations less so about FGM, but more so about, I'm going to take my child with cerebral palsy out of the country for some crazy healing technique, and saying things like, well, I don't think that's a good idea. It's not what I'd recommend. I can't stop you. However, if you do decide to do it and anything goes wrong, I will call social services. So it's really a practice of being two-way, very open and honest. And you'd be surprised how often families are very receptive to that, and actually will at least respect your comments, even if they don't agree.
No, definitely, that's a really good point. Okay, so I think this may be our final case. So again, just have a little think about what you want to know. Maybe either say some questions out loud if you're watching with someone else, put it on a piece of paper, put it on the Padlet, but really commit to what you're going to be thinking about, what you want to ask. So right, we have a 7-year-old boy that's come in with their father. They have a past medical history of asthma. They are regularly prescribed a salbutamol, a beclomethasone, and a montelukast inhaler, or inhalers, I should say. And the father reports that his son's been using his blue inhaler much more frequently. He's been coughing at night. He's been having episodes of chest tightness pretty much every PE lesson or when he's running around playing with his friends. And you examine the child, you do a full respiratory exam, and all you really get is kind of a mild wheeze heard in the chest, but nothing else of any real note. So kind of what things do we want to know, but what safeguarding things are we going to be keeping in the back of our head? So again, I'll see if anything's coming through on Padlet. Okay. Nothing's coming through at the moment. There's a few more comments about the FGM. I do appreciate there is a slight delay between the stream and what will be coming through. But so what I was trying to get at here is, yes, most of your history is going to be focused on the asthma and the fact that this young chap, his asthma is no longer well controlled. He's on 3 inhalers. So how are we going to address that? So you want to know more about the symptoms, the timing, the severity. I would assume by now, whether you're kind of late into your medical school career or you are junior doctors, you can take a pretty good asthma history. So I'm not going to tell you how to do that. But things that I would want you to probably either ask about or at the very least have in the back of your head are, how many hospital attendances is this child having? How frequently are they coming in, particularly for their asthma? And that's going to lead us on to, medication compliance and technique. So even in our adult patients, you say, are you comfortable using your inhaler? And they say yes. And you go, well, show me. So we really want to check that he's using it correctly, that he's being provided with an inhaler. He's 7 years old. If his compliance is poor, it's not really on him, is it? It may be someone else in the family is using his inhaler. It may be he's sharing it. It may be that, there's not a good engagement from the family with healthcare. And that's kind of what I was getting at with the home circumstances. And it could be, he could be getting bullied at school, so he doesn't use his inhaler or take it with him to PE. That's, for someone that's age 7, sometimes not being made fun of is more important than controlling their asthma. And you might think of as an adult, oh, well, that's a bit silly. But to them, it's the not being made fun of and fitting in that's more important. But it's having that conversation, or again, maybe asking one of your more experienced colleagues to have this conversation to gently kind of push them in the right direction. Thinking about how school is handling the asthma, think about, again, relationship with father. Is there any signs at all that you've come across of neglect or emotional abuse?
Just to jump in at that stage, the things I want to know. So we talk about taking a really good asthma history. I see terrible asthma histories all the time. So the key things I want to know, and you can do it in 2 minutes, got it down. You want to know how many times they've been in the last year. You want to know how many times they've had steroids from their GP. Have they ever needed HD or ICU level care? And does anyone smoke? Medical students out there, you are probably way better at doing this than our junior doctors and your senior colleagues. We forget all the time. But it's so important because if nothing else, you have an opportunity to disease prevent by offering them smoking cessation advice.
No, fantastic. Yeah, no, absolutely. Bringing it into all the key things that we need to be asking there. And that is going to be the focus of a history in real life. This is what you're mainly going to be focused on. But we just want you to have in the back of your head, make every contact count, always be aware that there could be other things going on. And that doesn't mean that it has to be the number one priority in your head. You know, the number one thing is properly investigating their asthma, isn't it? Exactly as Dr. Armstrong said. Okay, so I was speaking to a couple of my colleagues that are junior doctors, and they were saying actually the thing that scares them most is talking to the parents, particularly about safeguarding issues. So what are we going to be telling them? So we spoke about this before, didn't we, Dr. Armstrong? So it's not ideally parents need to be informed. Absolutely, every single time the parents will need to be informed of the fact that you are making a safeguarding referral and that you need to explain the process to them. Now, the timing of that and how you do it will kind of vary. So did you want to jump in there, Dr. Armstrong?
My biggest bugbear in life is a child coming up from A&E or from a GP surgery and the parent having no idea the reason they're coming to paediatrics is safeguarding. So the one thing I would drill into all you wonderful people is if you are sending them up with a safeguarding concern and that is your main concern, you must tell them, because otherwise they get to some poor sucker like me at 3 a.m. and I'm like, so do you know why you're here? And they're like, no, and I have to tell them, and they get very angry. Whereas if you tell them immediately and are really open, and as I was telling James before, the way I like to phrase it is something along the lines of, so there's several things we're thinking about here. And so let's take bruises. So this could be a blood disorder, this could be a problem with your platelets, or it could be that someone's hurting your child. Now, I don't know who that is, and that's not my job to decide. And I know that this process is difficult, but we have things that we have to do, and we're going to walk through it together.
No, that's a really nice way of approaching it. And I think actually, you know, if it's maybe on the less concerning spectrum, but also if just they're reasonable people, they will kind of understand where you're coming from there, and it feels slightly less personal, because it's horrible being kind of accused of that sort of stuff or thinking that might be going on. But you know what? The child's safety comes first, doesn't it? Making a couple thousand parents a bit uncomfortable, I'll do it every time to make sure I don't miss the one child that really needed that help.
The other thing that's going to really help you is use the opportunity to use the child's name. So if you say something like, well, you brought Jessica in to see us because you were worried, we're worried too. And what we're not saying that it's you that's harmed them, but if someone is, we all need to know that. And actually, as James said, most reasonable parents in that circumstance, like, yeah, I was worried, that is why I'm here. And they understand that there are processes that have to happen.
Yeah. And the big question we want to ask ourselves is, does informing the parent put the child at risk of harm? If the answer is yes, you know, we'll have discussed this with our senior, and it may be that things need to be put in place before we tell them. So that might be admitting the child to hospital. It might be contacting the police. You're an F1 or an FY2, you're not making that call. No, you're just not. Your consultant is realistically going to be the one that decides that. But we are going to tell them, like we said, absolutely every single time. But it may be that we've put a couple of things in just to kind of safety net and keep our child safe before we tell them those things.
So the absolutely classic thing for those of you who are aspiring pediatricians, and you know, I love accumulating my pediatricians, is in the Royal College exams, they will have a parent who is a safeguarding case. It'll usually be a burn. The idea is that they've caused it, and the one thing that they want to do is take the child home. And all you have to resolutely do as the junior doctor in that scenario is say that you cannot take the child off the ward.
Absolutely. So yeah, absolutely ask your seniors to help. They may even take over, or you can ask them to take over if you feel out of your depth. There's a good chance you are, but we will have lots of helpful people around you, and that is nurses, doctors, HCAs, the security team, whoever it is. But use your seniors. These are delicate conversations, and bring someone with you as a kind of a chaperone witness. So if there is any confusion, any kind of upset or where, everything gets very emotional and things get taken in the wrong way, it's good to have someone else there as a witness.
But what I would equally say is we always want you to be learning. And so if you've had the opportunity to see someone have one of these conversations and you are involved in the case and you want to lead it, I am more than happy with my juniors to come in with them and just stand behind them as their backup. Let them do all the talking and just jump in if things go bad. Because you guys actually have a lot more skills that you probably give yourselves credit for. And you do so much communication teaching nowadays that you actually you're very good at your jobs, guys. So believe in yourself. Just take someone to be your like backup.
No, absolutely, yeah. Take those opportunities, and no, that's wonderful. I mean, getting the opportunity to see this stuff and learn from your colleagues is next to none. Okay, so. I think we're drawing towards the end. So this is a slide on automatic referrals. Really important point. An automatic referral does not mean it happens without your input. You still have to do the paperwork. You still have to make sure these things get referred. So head injuries in under ones, FGM we've spoken about, any trauma in a non-ambulant child. So that is burns, scalds. It can even be small bruises. You still have to make a referral. Obviously, if you get a disclosure, you will be referring it, even if it's the fourth time that week that they've told a junior doctor on the ward about this. Doesn't matter. You document it and you refer it. There is no excuse for not doing this. Did you want to jump in there?
I was going to say that I would genuinely rather receive 10 calls overnight about safeguarding where I can say to you, it's okay, just write it down. We don't need to do anything else, than miss the one time when it's important.
No, absolutely. An interesting one that I came across when I worked in the Children's Emergency Department in Coventry, dog bites from a known dog. So even if it's a perfectly good story of, okay, my 3-year-old was poking the dog in the eye because they thought it was funny, and eventually the dog just turned around and gave them a little nip, and it kind of just scared them. Doesn't matter. It is a safeguarding referral. Social services will send someone out to assess the dog. But if that is what happened, where someone's pulled on the dog's tail or is just just being horrible to the dog, they're not going to put the dog down. They will do a thorough assessment. It is not just we are going to put down your dog, but if it is a known dog, whether that's in the household or a family friend, you can track this dog down. You do need to do a referral. And that can actually be the ones that I have noticed are quite hard conversations with people. As a dog owner myself, I can say I am incredibly attached to my dogs, and people can get very upset about this. Any unexplained injuries that don't match the stories, STIs in children, self-harm, suicidal ideation, or just if you're concerned, you need to be doing the referral. This is not an exhaustive list. It's not every single thing that you need to be referring. But if any of these are present, even if in some of them like a head injury in the under one, even if the story makes sense, it still needs to be discussed. It still needs to be referred. And if you're unsure about whether or not something does need to be referred, again, just ask. I mean, I've said it so many times this evening, but it is very, very important. Okay, so what is it that we want you to actually do? So make every contact count, have safeguarding in the back of your head, document your concerns, do it thoroughly, do it well, inform a senior and discuss it with them. And then fill out your appropriate paperwork. So that might be a MARF, which is a multi-agency referral form, or a MASH or a MASH referral is what it was called in Coventry. So that's the multi-agency safeguarding hub referral. The paperwork itself is self-explanatory. You just need to track it down and fill it in as thoroughly as you can. But it basically means it gets sent out to social services, the police. They involve people from the school, from any other kind of contacts that they have. And it's kind of an MDT meeting that they then discuss the child at. There's an information sharing form that we use at Stoke Mandeville. So it's a similar referral, but it's where it doesn't meet the threshold for social services input. So it might be we send the health visitors around just to give the parents a little bit of advice and kind of put them back on the right sort of track. And again, CAMS referrals, even if they're known to CAMS, if it's a new presentation or a presentation to the emergency department, you need to be making them aware via referral. And it is your responsibility to do it as the doctor, and do it straight away. Don't do it when you come in a week later. Do it while it's fresh. If that means someone waits for an extra 20 minutes in the waiting room, so be it. It's important. But that's it. Like, when you look at that list, it's not that scary. It's not that difficult. Most of your medical students that are watching, they will be able to do this as well. But just
sometimes when it's been really busy on the unit, I've got the medical students to do this.
No, it's good experience. And again, it just needs to be done, and it needs to be done properly.
My other top tip would be, just to add to that list, some of you probably won't yet think about the phone calls that come into your unit or your ward. If you get phone calls from parents looking for advice about their child, even if it's about, so we have a 24-hour open access policy after someone's been in. It's really important to document those discussions too. We never used to, and we now have a policy where we document all of them because of either poor advice that was given or advice that was taken incorrectly by a parent and misinterpreted. So essentially, if you're having a contact with a family, write it down.
Yeah. If it's not written down, it didn't happen, and it is very important that we know exactly what's going on. Okay, so we've got some resources here, just places that you can learn more. There's actually some very good, nice guidance. If you look at actually how to do assessments and maltreatment, things like that, they break down every possible thing that you might encounter or need to ask about. The GMC are the ones that they are, as you know, the ones that set the kind of agenda for what level of training we need, what our duties are as doctors. There is e-learning out there. I'm not going to say any more about e-learning. I'm sure you have your own opinions of it. But the Royal College has actually some really good documents on it. So one of them is the Safeguarding Children and Young People Roles and Competencies for Healthcare Staff, which I looked through thoroughly while making this presentation. And it documents basically what your responsibilities are at different levels and how your training should map to that. And that's all kind of skills and competencies, and tells you what you should be able to do.
And then the other thing that the Royal College has is what used to be the Purple Book, for those of you who have maybe worked in paediatrics, which essentially gives you how to do a safeguarding medical and how to write reports, but also what used to be Cardiff Core Info, which is all the research that's been done into safeguarding over the years. So if you ever are writing a report or helping to write a report, it's all the statistics that are going to back up those facts about subdurals on CTs in children that have had a head injury and non-ambulatory children. And if you see a burn that's on a cheek, why that's not okay. All of that is on the RCPCH website, and it's accessible to all.
Yeah, that is a really, really useful resource. So definitely check that out. And the last couple of things I put there is the Children's Act is where a lot of the legislation comes from. So if you are looking through some of the paperwork, a Section 17 is a child in need. So that might be a looked after child or a child that is just more vulnerable. A Section 47 meeting is about a child that we suspect is either suffering or is at risk of a significant harm.
So when a child's on the ward and you've referred them up to the likes of me and I do an assessment, I'm doing a Section 47 medical. Yep. And social care will talk about doing a Section 47 investigation.
And then again, the key point that we've hammered in, I think you get it, you're probably sick of hearing it, but ask senior colleagues, ask the more experienced colleagues. You know, that can be the band 6 nurse that's running the shift that evening. They have a wealth of experience, and you will have named safeguarding team within your trust, and you can absolutely rely on them. Okay, so last thing, if you do have any questions, please do stick them on the Facebook video and we will try and answer them now. I know we've gone a bit over time. We had some technical issues in starting, a few technical issues after we started, so I do apologize profusely for that. But we'd really appreciate if you take 5 minutes and give us some feedback. If you scan this QR code, there's also a link on the event. It will take you through to the Medal website where you can fill out a survey. Once you have done that, you will get a certificate saying that you attended this, and you can use that if you're a foundation doctor. You can use that as kind of for your portfolio. It's like CPD time. But equally, if you're a medical student, it shows interest. It shows that you've been trying to get out there and learn the important things with pediatrics. We will be using that to either improve both I should say, to improve our webinars as we go through the series. But also it's really useful information for us for research, and kind of looking at how people view different areas and the training that we provide. And also this particular one is how you view the mandatory safeguarding training you've probably done through your trust. So please do take 5 minutes to do it. Give us some detailed answers.
Also, if you do want things like that I could provide, such as if you do want to see pictures of awful things, but that you might not have come across and you want to see, or if you do feel like you need more information on how to do a good body map and exactly what you need to write, let us know, because we can always do more sessions if you think that's helpful for you.
Absolutely. So I'm just checking the video now to see if any specific questions are coming in now. I am aware that we've gone on for quite some time now, so I will be checking in, and I can always relay questions to Dr. Armstrong afterwards in kind of the week that follows. Equally, the poll and stuff, the feedback and being able to get certificates again, it stays open for about a week. So if you do watch this on catch up, whether on Facebook, and it will be uploaded to YouTube, and I think the medal as well is where it goes. Just refresh it one more time to see if anyone has anything they want to add. Otherwise, that might be all for us this evening. So thank you very much for joining us. And thank you, Dr. Helen Armstrong, for joining us. I very much appreciate all your input. I will just turn off the stream, and hopefully we will see you all next week. Do check your Facebooks, and we'll be announcing which speaker is taking the talk and what subject it is on. Okay, so